The present clinical situation describes a young patient who was referred to the clinic with a missing central incisor 21 and an implant being placed in the respective site. The patient is an Afro-American male who does not smoke and drinks occasionally. Following a trauma on tooth 21, an implant was placed and the patient referred for an implant-borne reconstruction. Upon clinical examination, severe horizontal and vertical contour deficiencies are present and a decision was made to perform a soft tissue grafting procedure. The risk profile illustrates that the patient is healthy, he has some high aesthetic requirements, he has a medium-high smile and a medium or medium scalloped gingival biotype. Looking at the teeth, they are rectangular and we do not have an infection at the implant site. Also, the bone height at the adjacent tooth side ranges between 5.5 and 6.5 millimeter from the contact point, which is of medium risk. The restorative states of the adjacent teeth, they're both intact, and looking at the width of the tooth gap, we have a distance of about 7 millimeter. The soft tissue anatomy is currently intact, but we do have a horizontal and vertical defect. As a first step to perform the soft tissue grafting procedure, a split thickness flap is prepared crestally on top of the implant, but also on the buccal side. Following the preparation of the split thickness flap, we can see, and also due to the releasing incision in the periosteum, we are able to advance the flap more coronally. Subsequently, the fibro-gide is shaped to match the desired defect site, and thereafter the fibro-gide is being sutured using horizontal matrice suture towards the palatal aspect. The entire matrix is subsequently placed on the buccal side, inserting it into the pouch. Following the placement, the initial suturing with a horizontal matrice suture towards the palatal aspect, primary wound closure is obtained. Two months later, we can see a clinical view having performed abutment connection. The subsequent steps include then to use a provisional reconstruction fabricated by a dental technician, and by using this provisional reconstruction, we can add some flowable composite and we can shape the emergence profile. Here we can already see the blanching of the tissues due to the pressure of the provisional reconstruction. Following a certain healing phase, usually between 2 and 3 months, we can see the final emergence profile that was established with the provisional reconstruction. Finally, we take a final impression and we can insert a final implant-borne single-tooth reconstruction made with a zirconia abutment and directly veneered ceramics. The final view 1 year after the insertion of the final reconstruction shows very pleasing aesthetic outcomes. Also, the patient is happy and the periimplant tissues are healthy. No bleeding on probing can be observed. The current clinical case demonstrates a clinical benefit in terms of aesthetics, applying a collagen matrix to augment the soft tissues following implant placement. The use of a soft tissue substitute reduced the treatment time and resulted in a decreased patient morbidity as well as an excellent clinical and aesthetic outcome.